name is Samir Altaki. I'm the General Director of the Orient Research Center. It is a special privilege for me to host, by the name of ORC, to host this session and host this forum. We are intending to build a scientific forum aiming to bring together the public health and the highly scientific analysis of the disease and the crisis with some economic perspective. That's why Mario had played a major role in the preparation of this. We are really privileged to have our colleagues from the United States, from Harvard, and from other institutions from one side. And of course, it's a great honor to have our colleagues from the United Arab Emirates. Some of them are especially leading very important positions, either in terms of scientific and epidemiological treatment from one side in the United Arab Emirates, and from the other side, some of them are working directly in the planning and the setup of different policies in this regard. So from my side, I would like to just to introduce myself as in career, I'm a medical cardiac surgeon. I'm no more practicing since more than 10 years, so that I will try to reflect this situation, those questions that are really taking very much importance in those days. You know, we have now Steve Jobs. We have no more Jobs. We did have Johnny Cash, and we don't have any cash, and we did have Bob Hope, and there is no more Bob Hope. There is no more hope. This is a big question, I think, at this moment. And I'm really amazed by the fact that the humanity is surprised again by a simple fact that health is the most important thing for a human being, and is even more important than the state security issues, etc., etc. From the other side, I would like to say that this crisis had been predictable. It's not like 9/11, which was very difficult to predict. While in the United States, we did have very big institutions, very big budget dedicated for the bio threat. And it was very much knocking the door, and there had been lots of prediction. What's really terribly amazing and really sad, that all those institutions were not able to tackle appropriately something which was on the table, was predictable, and practically many institutions had been established either in the United Kingdom or the United States or in France or even in Russia to prepare for a bio threat, and unfortunately it is a terrible failure. From the other side, it's very important for us to try to understand, I think, why a country like Taiwan, like Australia, like Korea, like New Zealand, who are so close to China, managed what are the measures, what is the privilege, what is the secret in it? They managed to give triple their better result in comparison with the death toll in comparison to the United Kingdom or in comparison to the United States. So I think now we have very important concerns about how could we return to work. Locking down was never done in the history of humanity, but only had been done after the 1914 World War I. But now, how can we return to this, to work? How can we return countries through physical distancing? What are the conditions? Testing, promoting testing, and individual tracing. My point of view is that we shouldn't aim at the moment to get back to a normality. We should aim much more how to return to functionality rather than simple returning to normality. There will be no normality in the foreseeable future, I think, in the current conditions. So how to refunction the society, refunction the economy and the normal life of people. So what is sure is that history is not written, we will write it, and it's only possible now to do it together. It's not through supremacy or hyper-nationalism that we can do this. It's by cooperation, being so humble vis-a-vis the nature and vis-a-vis human being. Thank you very much. I hope I just transfer my small introduction to Mr. Mario Vanella, who will be leading this forum. I have a suggestion that this network we are building now, it could persist for a long time as a tool to incorporate scientific work between Harvard and many of our Emirati institutions to exchange expertise and to build up cooperation at different levels. So we are putting this in mind very much. It is sad that we are profiting of such a sad situation to make such a step. We should have began it quite before. Mario. Sorry for...
Thank you, Dr. Samir. Thank you for your welcome notes. I'm Mario Vanella. I'm the Chief Economist of the ORC. I will be moderating this panel. Let me first of all say thank you to everyone that have found the time to come here. Considering the quality in this panel, I'm sure that the results will be nothing short than fantastic. As an economist, just giving a short introduction of what we will do and how we will plan to attack the multiple issues. As an economist, the majority of the talk right now, it's in what the recovery will look like, what shape of this recovery will have. And in a way, this makes perfect sense. We are all human beings, and we all want to move forward to a new phase of this crisis. At the same time, however, we constantly look at medical studies and showing that the virus situation could last up to 2 years. And with all this wealth and medical information that is coming out and we have in our hands, there are a few things that are clear. Among the multiple things, however, we decided to focus mainly on 4. The first one is that this is an healthcare crisis. And as such, no economic solution can be found without an healthcare solution. And I would be very explicit on these points to make clear my position that I think it's widely supported in this panel, which is that the so-called trade-off between the economy and healthcare is a nonsense. It's just ridiculous and doesn't make any sense, both technically under an economic point of view, and I believe under a human decency point of view. The need to find a solution for the healthcare demands that we understand the ins and outs of the virus, and something in which Dr. Madani will help us with. Understanding the virus, what we know and what we don't know about it, so the knowns and the unknowns, will progressively allow policymakers to take the right decisions in the future, strengthening the economic recovery as a result. Under this point of view, I'm actually looking very much forward to Dr. Madani helping us in understanding why training and formation of doctors on the field, something that I know she's very on top of it. What is called the so-called boots on the ground, why this is so paramount for the future development of the crisis. The second aspect that it's clear is, as an economist, is that data tell us that this is an healthcare-led recession. So it's not just a situation in which healthcare is under extreme stress under a logistic point of view, but instead is a situation, and I'm sure that it's quite surprising for the audience to hear this probably, in which US GDP data for the first quarter shows that healthcare contributed for nearly half of the GDP fall, and that's massive. And it's quite a strange world, the one in which we are living, in which we are in the middle of a global epidemic. And at the same time, the tool to face that epidemic is facing an incredible economic crisis. Of course, this is the result of a decline in physician services, and in lesser part also the result of the delay of elective procedures, which represented a fundamental step towards increasing capacity for COVID-19 patients. This has been the common case throughout the world, so every other country is facing the same. And I'm very curious to know the opinion of every panelist here, I fear that many countries have it backwards. let's take example the US, for instance. Out of 2.2 trillion, only 180 billion were directed to support healthcare. In many ways, also Europe was in the same situation. Let's not even touch the topic of emerging market and frontier markets. Of course, that's even more difficult. And it's clear to everyone, I hope, that a financial straight institution, in this case an hospital, it is in much more difficult position to fulfill its core mission. On this topic, Dr. Benz, who is the former CEO and president of Dana-Farber, will help us understand what are the policy needs and decisions that hospitals must apply to weather the crisis and to perform at best their role. The third thing that it's very clear and we'll be focusing is that we hear very different stories from different countries. As a matter of fact, we have a picture for G3 countries, we have a scenario for G7 countries, and a scenario for G20 countries, and another situation again for emerging and frontier markets. And this tells us, given this difference, that there is a fundamental need to share knowledge among countries and produce a global synchronized policy response. And I want to be very clear on this. This is not just because we want to help poor countries. That's something that really is not sustainable. What is important to understand is that this is self-interest, fundamental for the economy. In order to avoid the creation of reserves of the virus that will create additional waves and hamper then any effort of recovery. And on this, I'm sure that Ambassador Gooseby will have a lot to say on this topic, considering his vast experience. And finally, the fourth point is that I believe that COVID-19, and I'm sure that everyone agrees, has showed that political differences are in a nutshell irrelevant on some topics. We can dislike each other, and yet we are very similar in front of a pandemic. And we all depend on how other people, how the countries behave, and how they end up, and what they end up doing. If some countries are obtaining great results, for instance, in the fight of the virus, such as the UAE, the UAE, the country which we are, is a very good example of that, but the neighbors are not, then the result, the risk to be negative for everyone, and economies are not designed to constantly start and stop, start and stop. And on this, we're very lucky to have Dr. Andrew Witty from UNAIDS country director for Iran, and that will present the Iranian case, while Dr. Al-Muhairi, who is playing a prominent role in facing the disease here in the UAE, will present the US scenario. And I think I talked more than enough. And without further ado, I will just turn the floor over to Dr. Naveed Madani. Dr. Madani is the director of the SHE Center. She's at Dana-Farber Cancer Institute and the Harvard Medical School. And so, Dr. Madani, the floor is yours.
Thank you, Mario. Thank you, Dr. Samir. Let me share my screen. Okay. Salam alaikum wa ahlan wa sahlan, everyone. Ramadan Kareem. I'm very grateful for the invitation and organizing of this webinar to Dr. Samir and Mario. I'm going to tell you a little bit about our Science Health Education Center at Dana-Farber Cancer Institute, what Mario alluded to, as well as talk about the biology of this virus, because as Mario mentioned, it's really important for us to know the knowledge, understand how the virus operates before we can try to inhibit it and attack it. So the Science Health Education Center, the SHE Center at Dana-Farber, was really built on the backbone of our educational work that we did on another virus, HIV, because the Middle East and North Africa region is one of the two regions in the world that HIV epidemic is increasing rather than plateauing or decreasing like it is in the rest of the world. We initiated our educational work around HIV, and now the SHE Center has expanded this work to other disease areas. The SHE Center's mission is to empower the MENA-based healthcare practitioners and researchers to enact best practices in governance around public health with a focus on women's health, therefore strengthening the fabric of society through education and connectivity. The center has 4 pillars: training and standardization of healthcare practices by promoting best policies in medicine, scientific research, like I said, with the emphasis on building a female human capital and healthcare force. Also, we like to emphasize scientific and innovation in the region. And ultimately, we like to establish a two-way dialogue and training, how we can train, like Mario said, my favorite term that I have to say I borrowed from Dr. Fauci a few years ago, boots on the ground, training people in the trenches, in the field, as well as them training us, because this has to be a two-way scenario. So with that said, as a very timely example of the kind of projects and swim lanes that the SHE Center focuses on, actively focuses on and engaged in, is trying to make a positive impact on COVID pandemic that is currently destabilizing our world today. The next slide shows the clinical life cycle of the virus. Human coronaviruses are enveloped positive stranded RNA viruses that cause respiratory and digestive tract infections in animals and humans. 2 coronaviruses to date, severe acute respiratory syndrome, SARS-CoV-1, and Middle Eastern respiratory syndrome, MERS-CoV, caused deadly outbreaks of severe pneumonia and bronchitis. SARS was in 2002, and MERS was in 2013. And like Dr. Samir said, we knew something like this is coming. We just should have been more prepared. These coronaviruses, started in 2002, and now in December of 2019, we got SARS-CoV-2, which emerged in Wuhan, China, resulting in what we call COVID-19 now, that causes a severe respiratory disease in humans with around 2 to 3% fatality rate. Now, this number will likely change based on more testing and a better understanding of the actual infection rate. More accurate reporting of the number of the cases, as well as more accurate reporting of deaths as the standard of care in general in different countries evolve. The very efficient human-to-human transmission of this virus has resulted in the pandemic that we see now. The next slide is something that us scientists really rely on when we talk about viruses, is the SARS-CoV's life cycle. I want to focus on 3 areas of the life cycle for this virus. The entry is where the virus uses the host cell proteins on the surface of the cell to enter and invade. A replication of the genetic material of the virus is the next phase of the virus. It proceeds after the entry, and then packaging of newly formed virus and budding and escape of the virus from the host cell is the last phase of the viral life cycle. Now, for my group actually works on the entry phase of this virus. The virus has a spike protein or S protein that it uses to bind its known receptor, ACE2, and then fuse into the host cell. And then the genomic, the viral RNA is translated to genomic RNA, and the replication continues after packaging, and then virus is released. Now, any of these phases of the life cycle of the virus, the entry, fusion, genomic translation, and packaging, and viral release and budding could be targeted by therapeutics to inhibit the virus. The next slide brings us to the immediate goals for the current therapy. SARS-CoV-2 for treatments that we have right now. One, we can have passively administration of neutralizing antibodies that could improve survival. And second, small molecular peptides directed toward transmission of the virus. And that's something that our group is actively working on right now. Another small molecule that is being tested is Gilead's remdesivir. And this molecule is actually inhibits the correct translation of the viral RNA to mRNA during the replication phase of this virus. And we heard, I think last Thursday it was, that it's gone into, the results from the early phase clinical trial was very positive. Another urgent priority is development of a vaccine that could protect against SARS-CoV-2 infection. And although development and testing of a vaccine candidate will take longer time, vaccines will be extremely valuable, especially when this virus becomes endemic, and it would emerge seasonally and next fall. The candidate vaccine right now is in trials, is Moderna's mRNA 1273 vaccine. This is a very interesting vaccine in a sense that Moderna has used nanotechnology to deliver RNA into the cells. The RNA encodes for the spike protein, and it's the envelope protein of SARS, and that's actually the envelope protein that we are targeting. Our group has developed an assay to be able and test candidate small molecules and as well as peptides that inhibit the spike protein in vitro. I'm biased because in both cases of HIV and COVID, our group has emphasized on the entry phase, because I believe that it's entry, the virus is outside of the cell. It hasn't gone inside the cells to do the replication. And a lot of times it's easier for peptides and small molecules to access outside of the cells instead of trying to go through the transmembrane of the cells. So that's what we are doing as far as our basic science work is concerned. Here, I like to emphasize enhancing the way our drug development is done. Dr. Samir talked about how we have to kind of reformat things in order to attack this crisis. We have to really increase international cooperation and collaboration. A colleague of mine at Sharjah University actually has written a wonderful manuscript about how we can redefine drug discovery and involve more international collaboration. One subject also that we need to discuss is a fundamental improvement in clinical trial design and execution that is required to go into this design. The process right now, I believe, is slow and inefficient. One example in the area of cancer is adaptive trials that allow multi-experimental treatments and drugs to be evaluated simultaneously in parallel against a small control arm. These trials run under one master protocol, and many sites with potential of global trials can be involved. The adaptive part accounts for all the data generated in the trial simultaneously that allow physicians and clinicians and scientists to pick winning and losing therapies and treatments fast, shutting down the underperforming treatment drug arm and increasing the enrollment in the therapies at the same time. An example of it is I-SPY 2 for breast cancer and glioblastoma, agile for glioblastoma brain tumors. And I'm happy to say that a colleague has also developed a COVID adaptive trial right now. So with that, I want to go into, I talked a little bit about it, our immediate path forward. These won't be done, of course, overnight, but we have to start the wheels in motion, developing different therapeutic treatments that I talked about, redefining trials, establishing and ensuring infrastructure that will be adequate to handle the recurrence in the fall and other pandemics. And again, going back to my favorite terms, training our boots on the ground. While there are many challenges, lastly, let's see, getting the new normal, like Dr. Samir said, I don't think we're going to go back to what we had before, but defining the new normal within our healthcare system, within our hospitals, within our universities, training system. Our training has always been, face-to-face, but we are developing different platforms that we can do it remotely. All of these are going to be, extremely intricately and tightly tied to state and global economies and governments, and we really all have to come together. And I want to frame this around the term Dr. Samir talked about, and that is hope, coming together. There are going to be many challenges ahead of us, but I want to finish by saying that I'd like to be optimistic and thinking that by scientific collaboration and cooperation, we can get it done. And with that, I'm going to stop and give the helm back to Mario.
Thank you, Naveed. That was really full of information, I believe, for everyone, at least for me, for certain, and extremely interesting and fascinating. I will go now to Dr. Edward Benz, who is the former CEO of Dana-Farber Cancer Institute and currently Susan Smith Distinguished Professor of Medicine, Genetics, and Pediatrics at Harvard Medical School. The floor is yours, Dr. Benz. And you're on mute right now. There you go.
Can you hear me now? Thank you. Well, first of all, Mario, Dr. Samir, and Naveed, thanks very much for the opportunity to participate. While I've been the CEO of a hospital for 16 years, I'm actually a scientist at heart. And maybe just very quickly add a few comments to Dr. Naveed's presentation about the virus. One is that the successful antiviral therapies we've had that have been deployed on a large population basis are all multi-drug combinations, with the possible exception of herpes virus, which we only use for acute infections. But hepatitis C and HIV have become treatable because the viral life cycle was attacked at several points. And so my guess is that effective drug therapy will involve not only the polymerase inhibitor remdesivir, but a protease inhibitor. The viral life cycle initially makes this huge polyprotein that is chopped up into the 10 or 12 or so individual proteins that comprise what the virus needs to complete its life cycle and package itself. And those proteases are different from most of the proteases in the human body, so you can target them. So I think that will be part of what you see in form of drug development. There's also fairly complicated steps in that final set of packaging the virus and getting it out to the Golgi and sent back out to infect other cells. And there are targets there that could be hit. So if I had to guess longer term, that effective drug therapy to antiviral therapy will be a multi-drug combination. The other quick point to just make is that we're learning more and more about the actual management of the clinical syndromes. Early on, it was all focused on respiratory support and treatment of sepsis and cytokine storm, the things that are fairly common to all overwhelming infections. But it's now becoming clear, and I'm a hematologist by training, so this is of particular interest, that as part of that inflammatory response to the virus, there is a tremendous and I won't say unique, but very different kind of activation of the coagulation system. And this is why you're seeing strokes in some people. It's probably why you're seeing this remarkable degree of hypoxia, of drop in oxygen saturation, even before you begin to see the classical signs of changes in lung function. There are probably showers of small clots, small pulmonary emboli. So I think anticoagulation strategies are going to be developed when patients begin to show any signs of deterioration, hopefully before the O2 saturation falls. So that's just a couple of thoughts. And then finally, there's 9 vaccines in clinical trials now, I believe, and probably along with the Moderna, the Oxford adenovirus-based vaccine, which again uses a viral vector to code for the spike protein as the antigen, is getting into broader clinical trials. So lots of activity there, but I think the jury's still out on which ones will prevail. A concern with these vaccines has been seen with others, like respiratory syncytial virus and dengue, is that sometimes the antibodies you make don't kill the virus. They actually allow the virus to get into immune cells. It's called immune potentiation or immune enhancement. So that is why longer term follow-up of the use of these vaccines on a large scale, no matter how fast they're mobilized and produced, there's still a period of clinical observation that is just going to be a fixed point of rate limiting step in the development of the vaccine. So those are my sort of comments on science, but I think what Naveed thought I could offer is how institutions like those in the Boston hospitals, but I think typical of hospitals everywhere, even with some peculiarities to the United States, are going to be looking at getting back to the new abnormal, I think I'll call it, the new state of functionality. I like Dr. Samir's term of reserve functionality rather than normality. And in many respects, the prerogatives and basic premises you have to meet are the same as we faced when the virus was beginning to take hold in our. That is, first of all, providing adequate care services and, to patients, providing adequate protection to patients who encounter us in a place where we have a concentrated group of people who have the virus, but sick people coming in who do not have the virus and have other illnesses. So that is causing us, I think, not as a result of this, to begin to think of how we partition our care spaces in a more intelligent way than we've had in the past, and how we are adaptable in being able to either create spaces or modify our use and repurpose our spaces so that we can keep patients in a better way than we've been able to this time, keep patients who need care for all the usual things that we take care of safe from patients who have the virus. And of course, there'll be some patients who have both of them. This has an economic as well as a clinical care aspect to it in the United States, because the irony is that some small hospitals are on the verge of going bankrupt and closing. Even the big hospitals are undergoing major financial stresses, their credit worthiness, their ability to meet payroll. And this has to do with the craziness of our healthcare reimbursement system, but not being able to do elective surgeries, elective in-person visits where you get paid according to the number of organ systems that you examine on each visit, where you get paid almost not at all for telemedicine. So the hospitals have had a near shutdown of their usual flow of revenue. And a well-run hospital, with luck, runs on a 3 to 5% margin. So it doesn't take much to send the, and has maybe between 100 and 200 days cash on hand for operations. So it doesn't take much to put a hospital in severe financial stress. And we have ironies now where we have this overwhelmed healthcare workforce, and yet there's talk of laying people off. So I think as we go forward, we're really going to have to take a hard look at the structure of our care delivery and really take advantage of the attention finally being paid at the federal, state, and insurance company level to the way our reimbursement structures work to try to rectify this. We don't have this irony as we're providing the ultimate life-saving complex acute care that we're supposed to be there for and losing money hand over fist. So that I think is going to be one thing we'll see going forward. A lot of attention paid to that. The second is protecting the healthcare workforce and ensuring for going forward that we have an adequate, not just healthcare workforce, but public health workforce. And I think this is where Naveed's program is of great importance, is to develop that capacity of what we're calling boots on the ground for people who are able to function. They're not only there to help us cope with an epidemic, but also to be the early warning system, because they are the public health workers are frequently the first ones to notice that clusters of infection or clusters of an unexplained illness are occurring. So that I think is going to be another area where we have to address it. Our challenge for the short term is similar to many other sectors of the economy. We have people not coming in now with their regular healthcare problems. We have people sitting at home with the typical strokes and heart attacks and pneumococcal pneumonia, and they're afraid to come to a healthcare facility for fear of catching COVID. Or they're unable to get into the healthcare system because it's overwhelmed taking care of COVID patients. So we're going to have to, and I think the focus for the next several months is going to be on reopening in a phased way, a safe way to allow patients to come in for their, I'll call it routine healthcare, but also their acute care for non-COVID related things, so-called elective surgeries. And I think the first step is we will do things that are time sensitive, but not necessarily super urgent. So, for example, ablation for someone with chronic atrial fibrillation is time sensitive, but it's not necessarily urgent that it has to be done today, or the patient's at great risk of dying. Treating an acute myocardial infarction is, on the other hand, urgent, got to be treated no matter what the other circumstances are. So prioritizing and figuring out how to phase that in, figuring out how to be able to do that in what I described earlier as these safe spaces, I think will be the next steps for our hospitals here. And then second, we're going to need fairly quickly legislative relief from the constraints on telemedicine. If our doctors at Dana-Farber do a telemedicine consult in a patient in New Hampshire where we actually have a facility, they go to jail. It's practicing without a license in New Hampshire. So there's this hodgepodge of state regulations, whether it goes to reimbursement or legality of care. Telemedicine is one example, but there are others that I think will need to be addressed. And these are peculiar to the United States, but my guess is that as you look at health systems around the world, whether they're largely government run or largely more privately run, or whether there's a mixture, you're going to encounter these same dimensions. So safety for patients, safety for the healthcare workforce, financial sustainability, and then this vast web of regulatory things that have been put in with good intentions, but in this kind of an acute situation are getting in the way of the innovations that we need to get to the next step. So thanks for allowing me to comment.
Thank you, Dr. Benz. That was fantastic. You brought a lot of new points to discuss, maybe in another moment. And as an economist, of course, when you bring financial aspects, I get cheered up. It's something that I can easily follow. Thank you so much.
Mario?
Yes?
Yeah, this is Professor Walid Abu Hammour. May I say something about the science of this virus and the pathophysiology?
Yes, but if you can, you are speaking at the end of the first five, if you don't mind. So we can just go with the
Okay,
speeches.
sure.
Thank you so much,
Sure.
Professor.
Thank you, Maria.
We'll now go to Ambassador Gooseby. Dr. Eric Gooseby is current professor of medicine and UCSF, director of Global Health Delivery, Diplomacy and Economic Institute for Global Health Science, and former UN Secretary General Special Envoy on Tuberculosis. The microphone is all yours, Dr. Gooseby.
Thank you, Dr. Vanella, and Dr. Samir, and Naveed, and I guess Dr. Benz. It was a real pleasure to have an opportunity to hear your thoughts this morning, but also to participate in what I think is a timely but also important discussion. I think when outbreaks occur, it strikes me one of the early differences in looking at HIV versus the COVID kind of rollout of its threat. COVID occurs in fast motion. It accordions everything that occurred in HIV really over years. It's a fascinating comparison. But I will say that every issue from understanding that we had a new virus, understanding how this virus works from attachment, intercalation, the development of virus particles and eruption into the cell wall and adjacent infection, et cetera. That delineation of the natural history of HIV took a decade to do. And our understanding of the pathophysiology evolved concurrent with that, but also in spurts and stops. By the end of a decade, we began to have drugs that were therapeutically effective in AZT and 3TC and D4T, DDI, DDC, all those early 80 drugs. And then in the mid-90s, with the development, really understanding of ritonavir and sequinavir, we got the highly active antiretrovirals that then brought us in to a wonderfully creative choice of 36 different formulations that allow us to still, even in patients who are multiply resistant, to still have as the chief goal of therapeutic intervention, sterilization of viral undetectable. So a remarkable story, but it strikes me COVID has done it in weeks that took years for HIV to go through that same evolution. In that regard, though, mounting a response to something that is so comprehensive in its impact on society, hitting at every level, across the board, socioeconomic, racial, highlighting as diseases do all of the shortcomings in our delivery system's ability to identify, enter, and retain people in care. We see the same old problems showing themselves with the same populations. One of the things that that Ed's brought up, and I just wanted to amplify, violently agree with, is the extraordinary moment that was presented to us in trying to orchestrate and understand the resources that were present just in San Francisco as the outbreak occurred. Matching, meeting, and convening those entities in the city that are already responsible for patient care. Over half of our population is insured with Kaiser Permanente, and with private insurance of one type or another, a third-party payer. Our own university is competing with private sector physicians, and patient capturing strategies are going on in our city really for the first time in my academic life. But UCSF is late to this dialogue, whereas other centers have gone decades before. but it created a stuttered dialogue as we realized we were going to be in front of the outbreak as to who was responsible for what patient population, all of whom are San Francisco citizens. So I was pulled into the Department of Health's discussion, who views itself as responsible for everybody. But when you have over half of your resources being controlled by a private entity that has a profit agenda as part of their motivation, it stopped the dialogue for about 2 weeks. Who's responsible for identifying patients? Should we have one testing site? Should our case finding be something we orchestrate together across 7 hospitals, or should we do it just one hospital at a time, each one doing their own reflection of those needs? A similar challenge occurred with states from the lack of a federal orchestration necessitated the engagement of each state. And each state's inability to orchestrate necessitated the engagement of each mayor in looking at their PPE demand, where and who should be identified as high risk, how we as a heterogeneous response orchestrate that response, the sharing of brain power and resources and capability became a nightmare. And I just want to put that as a marker. All to kind of pivot into the international challenge is very similar to what occurred in San Francisco with divergent funding lines. International settings, especially resource poor settings, are always in a dependent funding line relationship with donors. The domestic investment is small compared to the donor input. Donor requirements around where, who, and how money moves into their country are strict and unyielding, rarely accommodate another donor's requirements, and almost never accommodate the domestic needs in creating a continuum of care and services that the Ministry of Health identifies as needed and blesses as their continuum of care. So the development of this international health regulation in 2005 was an attempt to harmonize and orchestrate our ability as a global health community to concentrate our response when an outbreak occurs. But it's dependent on the country having the ability to stand up a surveillance system that is robust enough to identify an outbreak, characterize it, and then alert the world to the fact that this is indeed occurring, and give WHO an opportunity to declare a global health emergency, which opens up immediate funding and the cascade begins. I was humbled by looking at the kind of developed world orchestration of a similar challenge. But I think the impact on populations in developing settings will be horrific and tragic if that orchestration is not done before the virus starts to capacitate, inundate delivery systems, especially sub-Saharan Africa, Southeast Asia. My experience in this has been I was in China working with the Chinese government from about 2000 until 2008. In that time, was working with them as the only external consultant to their ability to stand up what turned out to be 300 treatment sites for HIV, combined with drug treatment and needle exchange programs for those portions of their epidemic that were driven by drug use. This was a large portion of their epidemic. So as I say, we had 300 plus sites that went up. During that discussion of and definition of unmet need in the early 2000s, we saw the SARS outbreak began in 2002, and were very much involved in cajoling with WHO the use of sorry.
These are the pandemic issues. It's quarantine issues.
That's a phone call from my daughter. So the SARS response in Beijing, orchestrated by the CDC, Chinese CDC, was an iterative one where China, hesitant to reveal ignorance, quite frankly, and not willing to bring others in to help them think through a problem, did everything kind of covertly, but brought in expertise to help them think through it and mold their response. I would attribute WHO's orchestration as the critical ingredient to that, but it was my first encounter with the COVID. And then in my work with PEPFAR, where from 2008 to 14, took PEPFAR through its acceleration phase. The first episodes of PEPFAR presence in 15 countries really established what I would characterize as a service capability that predominated in capitals. 3 to 4 clinics, 1 or 2 hospitals. That's mostly what the footprint looked like in 2008, 2009. And that second phase that came in with the shift in administrations to President Obama's aggressively accelerated movement outside of capitals, went to rural areas, followed the geomapping of where the epidemic was, and developed the blanket responses that covered the country's needs, procurement distribution systems that matched that, and an orchestration of resources that included a large donor footprint, but insisted on weaving in domestic and other donors to really diversify the portfolio so it was more resilient. And I think we're largely able to do that with I think, less domestic investment than would have been optimal, and that problem still remains today. So I guess I would say the COVID response to me, we now, UCSF has taken over for the Department of Health in San Francisco, the case finding and contact tracing efforts. We have launched a number of surveillance pieces that will give us an understanding of how far the virus has penetrated into the population in the local neighborhoods of San Francisco. We think that our ability to establish an asymptomatic cohort, we're doing that, and looking at therapeutic interventions, the remdesivir in particular, but also some immunopotentiators and in combination with kind of antiviral drugs as well. So already looking at combination therapies that you alluded to before. I think that our ability to respond globally to this is not where it needs to be. I think for WHO to be challenged and attacked right now in its ability to play that convening, orchestrating role needs to be put on the back burner. We need to invigorate their ability to play the role that's needed and that they can play. And I'm confident that they can do that without a doubt. The criticisms have been misplaced or unfair, and I think are playing a political agenda out that's U.S. domestic in its origins, and we should just stop it. But I do feel that it's going to be a fight. I guess my final thought is in making, really emphasizing what the entire group has said. I think the big epiphany for me has been seeing the convergence of the conversation that has not occurred in the United States, i.e. managed care versus third-party payers versus a public health safety net. We have not understood the multiplicity of needs that presents, and our delivery system has not orchestrated responses to those needs that identify, enter, and retain the most vulnerable individuals in care and treatment services. Once again, an aggressive medical problem has highlighted all the weaknesses in our cascades, and I'm hopeful that this time it will precipitate that broader discussion that needs to occur for us to take care of all of the people in the United States and on the planet as this COVID runs its course. I believe it will rekindle, I hope it will rekindle a universal health coverage need that is more urgent, more pertinent, more relevant to the political systems that have been talking about universal health coverage for 7 or 8 years, but without the urgent understanding of the importance that a safety net delivery system plays for the populations on the globe. So I'll stop with that.
Thank you so much, Ambassador Goosby. Extremely interesting. You also brought up inequality and international cooperation. Inequality was also something that Dr. Benz brought up. This crisis, this economic crisis, will produce more of that. Market concentration and resulting income inequality. This would be very, very interesting to talk maybe in the second half of this conversation. We move now to Dr. Durudi, who is director for UNAIDS Iran, and I'm sure that he will also have to add a lot in this talk. Thank you.
Good afternoon, everybody. I would like to thank sincerely ORC, Dr. Samir, Dr. Vanila, Dr. Madani for giving me this opportunity. Also, warm regards to colleagues from United Arab Emirates and United States of America. Let me start by a quick overview of COVID epidemics in Iran. As of yesterday, a total number of approximately 97,000 COVID cases were confirmed in Iran, including about 6,000 deaths. It's noteworthy that more than 78,000 of them recovered. About 46% of confirmed cases are female, and about 26% of them have at least one underlying condition, cardiovascular, diabetes, and asthma are on top of this. Approximately 59% of patients are over 60 years of age. The important point here is that both number of new cases and number of deaths are following a crescendo trend during the past 2 weeks, which has resulted in some changes in prevention measures by the government. The national response to COVID-19 in Iran was based on the whole government and society engagement, intersectoral collaboration under supervision of a COVID response task force or command. Implementation of case identification, contact tracing, social distancing, smart distancing later through society awareness raising and sensitization, mobilization, and voluntary engagement took place. It also involved a massive mobilization on various infrastructure of the country, registering cases online and by phone, recruitment of 170,000 health workers, establishment of more than 1,000 selected comprehensive health centers, which work 16 hours a day to provide active case finding and other services. Establishment of quarantine units to provide pre and post hospital care services to COVID patients, and launching of more than 500 COVID test units in selected primary healthcare centers. More than 2 million small business shops and industrial units have been registered in the Register of Ministry of Health to ensure that the social distancing is being observed by everybody. In addition to that, the country has mobilized its research and scientific capacity to conduct more than 1,000 research projects, including more than 140 clinical trials, publishing more than 250 articles, and also joining Solidarity mega trial with 50 hospitals in 60 provinces. As I said, the country has mobilized its infrastructure to increase production of diagnostic kits, masks, disinfectants, gloves, ventilators, and other medical needs. It's noteworthy that at the beginning of the epidemic, we used to receive demands or list of wanted items from Ministry of Foreign Affairs, which mainly contained masks and disinfectants and gloves. But now we have been informed that the country does not need these kinds of things anymore because it has become self-sufficient production of these materials. I would like to draw your attention to the lessons learned and way forward from a regional perspective. I believe that it is true that effectiveness of a response to any epidemic depends on effectiveness and thoroughness of its preparedness. It is also true that we are all students to this virus. Many aspects of epidemics remains to be unfolded. Therefore, novel as the virus is, we should think out of the box. I think epidemic can be reversed only by highest level of political commitment. And from health perspective, from public health perspective, it means evidence-informed and people-centered policies and programs aligned with global and regional solidarity and collaboration. And this is the area where I want to emphasize more on. There are many lessons from COVID and HIV responses. Both diseases have similarities and differences. One worth mentioning, I believe, is promotion of international collaboration to respond to epidemics. As Dr. Guzbi mentioned, history, for instance, in Iran, history of our collaboration with She Center at Dana-Farber Cancer Institute at Harvard University, an Iranian health care system, and its significant results in terms of improvement of lab quality control, improvement of knowledge exchange, and improvement of pediatric treatment, all prove that international collaboration has an important role in combating the disease. In addition, Iran COVID response results that I mentioned earlier did not take place in vacuum. United Nations and other multilateral international organizations provided technical and supply support. But it was not limited to multinational organizations, but also countries through their bilateral relationship extended their support. For instance, United Arab Emirates not only sent medical aid to Iran, but also supported the United Nations assistance to Iran by its air logistics support to UN when almost all international airliners had stopped their flights to Iran. We provided a chance for converting threats into opportunities for strengthening regional cooperation, as HIV provided the same opportunity for global collaboration. And all these efforts paved the ground for a more advanced health diplomacy in this field. I believe that there is a significant pool of experience in public health sector across the world. I think we need, for this region, we need a hub for exchange of knowledge on good governance and response in the field of health, as was mentioned earlier in speakers' words. A knowledge hub for experience exchange, knowledge translation, knowledge transfer across the region and globally. A center for cultivating and dissemination of good practices in the field of good governance, public health good governance. And I believe that knowing UAE strong infrastructure and long-standing investment in this field is in a very good position now to pioneer such initiative. Thank you.
Thank you, Dr. Drury. We'll move now. You brought also a lot of topics, particularly on the collaboration side, for instance. Again, it's something that we should probably will not have the time to explore all the topics that have been brought up, but extremely interesting. We'll move on now to Dr. Bader Sultani Al-Maheri, who's family medicine consultant, member of the Emirates Family Medicine Society, and he has been on the front line here as contributing to the response to the UAE. Please, the microphone is yours.
Thank you very much, all of you, and I appreciate to invite me to be one of the speakers today. Do you hear me very well?
Yes, perfect.
Yeah. The experience in UAE started when the news came from China. And I was one of the involved in the committee in the UAE to prepare for this new experience and for this virus when it came in around November and December. So UAE started to develop, a module which is different from the other countries, as each country has its own modules, and each country knows its capability and what they have for facilities and everything. So when the UAE started, it has so many elements which help this UAE modules to improve and to be strong, as everybody now see all around the world. One of the elements which has helped UAE modules and experience how to slow the effect of COVID-19 in UAE is the leadership. We have very strong leadership from His Highness Sheikh Mohammed and other leaders in UAE, which help us a lot, which they interfere and give support for all the teams from the physician and the economic people and other politicians which support us. So the other points which make us, UAE modules very, stable, the economy and stable of UAE. We have very strong finance support in UAE, so to make our modules very stable. So with this economically stable and finance support from the government, it helps us a lot, to be honest, in our in the flooring and helping all the private and the government sector to be in one element in controlling this COVID-19 epidemic. And one of the third elements, to be honest, which help us the quality of the health system what we have. Yes, we are new. We have very good quality service in UAE from Fujairah to Abu Dhabi. We have one good system. So this quality of the service and the hospital from government and the private sector, to be honest, help us a lot in this crisis. And both sectors, to be honest, work together since the start of the crisis as one team. So we started to invest from the clinical point of view and for other things to make sure everything is stable. One of the elements also what helped this is the UAE modules, the readiness. So we start to see, are we ready for this crisis? From food, medicine, and PPE. I was, to be honest, afraid what we get from other countries, but to be honest, we get enough supply from food and medicine and PPE. And if you see now, most of the hospital now in UAE, they're having full support to protect their staff. And if you see in the numbers of affected physicians in UAE, it will be quite low compared with different countries. And the other element which help us for UAE modules and strategy, it's ready infrastructure. If you see now from the roads, from the transport, and from the internet, it's really well-built system in whole UAE. Nobody affected from the private sector and from the public also. They are working together. And one of the elements also help us, we develop using the smart technology. If you see now, we adapt like other countries, using the smart things to adapt in our crisis. So I summarize it, UAE's strategy come for 5 elements. These 5 elements really, they start to work together. Like the first element for our modules, very strict measures. UAE started their strict measures in the middle of our February, but it will become very active and very strong in the early of March. If you see, we starting social distancing, we stop the flights, gathering, and the mosques started to close, and all worship also start to close in the early of March. It is really started very hard in the beginning. And if we see that according to statistic, when in the early of March, when the number of infected people started to be raised around hundreds, really the government start very sharp. But in a way, it will involve the community. This is the best things the UAE modules started to involve the community. We have multinational of people from different countries. The UAE use their resources to pass the knowledge to this community. We need to get all together, supported to each other to get over this crisis. To be honest, it was a hard work for the media people and other leader and politician, to be honest. One of the second things for our modules, the UAE government ensure easy life for the people. Tell them stay home, we'll support you all together, we'll do whatever you do, but stay away from the overcrowded. And to be honest, they started very slowly. If we see the restriction when it came, it's very new for us to stay home, not to go out to take a normal life. It started slowly. If we say from the early of March, it is half days, so there is a restriction. Then when the government take a hard decision in the early of April, it was completely lockdown, where the people understand, yes, this is the time we need to support our government and our teams. The third element for our UAE modules, to be honest, UAE government support the business. You see, that's our central bank announced in the early of March. It is supporting the business and all the bank around 100 billion dirham, which is, to be honest, quite a lot of money. And Dubai itself supported the small business and medium business around 2 billion to make sure the effective crisis to our small and medium business to get, very, very slowly. One of the things, to be honest, we have to mention in UAE strategy and the module, how to control it, our humanity. UAE start to support most of the countries all the region around us, from Saudi, Kuwait, and Iran, and Pakistan, they are sending whatever they need to support them, from ventilators, PPE, which is really a great things from your government. Still, we are in crisis, but putting hand, we know we need all the countries to get supported between each other to get over this crisis. And one of the last things in this UAE modules, to be honest, which I like it, they make the challenges to opportunity. What I meant by this one, we never hear about driving through for testing. We get to the decision to use real-time PCR to get to test these people in the street or in other departments. They make within 2 weeks more than 14 drive-through all over UAE, and start to test more than 26,000 tests a day, which is really a challenge things for us, very new for us, but really at the moment, this is the UAE modules. Thanks God, it's supporting us. We are at the moment we are controlling this crisis, and one of the things we know, the element for these modules and the strategy will change as the virus get control over. This is the talk from me, to be honest, and thank you a lot.
Thank you, Dr. Harry. Very, very good presentation on the side also of the UAE. You touched on an important topic, which is finance and politics. Stability in the region is a problem. Other countries are not at the level of the UAE, of course, in that sense. And also capital is another issue, right? Of course, the UAE has worked his way towards that level of investment and the ability to react fast. As a matter of fact, I think the UAE today is running the top 4 of testing around the world, which is quite impressive. I will have to ask then from this moment on that we finish the first round to the commentators to stay a bit shorter statements, probably below 4 minutes if possible. We'll move now to Professor Walid Abu Hamur. Sorry for my enunciation in Arabic, definitely not my language. He's professor of pediatrics.
You need the course in Arabic, Mario. It's a big problem now.
I work too much with that, though, unfortunately. I need more free time. But Professor, it's your turn. Please, if you may stay below 4 minutes and with your comment and question. Thank you.
Thank you, Mario. Thank you, Dr. Samir. I'm grateful to you for inviting me for this interesting workshop. Also, I would like to thank the speakers who spoke before me. Very interesting, informative talk. I would like, to talk in general about this COVID-19 pandemic and what I have been learning and what I have so far reached to conclusions. First of all, regarding this virus, we know it was originally from animal to animal, then jumped to human, and human to human. This virus has the capability of having mutations. So far, few mutations have been identified, but it has potential to have many and several mutations. Most of them will be silent, but we don't know when the non-silent one will happen, and it will be another threat for the whole world. We know that this virus does not respect borders and also does not discriminate between developed and undeveloped countries, between poor and rich. So this is another new things about this virus. We know it is disaster for the whole world, but I think it is wake-up call for the whole world, and wake-up call to look at the gaps and weaknesses. And to be honest with you, this virus exposed, if not the whole world, many countries were exposed by this pandemic, COVID-19. this is one part of this virus. Regarding this virus, so far we don't have any treatment, and we don't have any vaccines. And the other issue, I would like to say the literature have been intoxicated with hundreds of publications, and unfortunately, majority non-peer reviewed. And we have to be careful when we have to interpretation of any study coming. And we clearly have seen, many drugs they were used, and now there is alarm not to use these medications. I agree with my colleague who spoke before me regarding this COVID-19. I look at it like simple infection, viral infection, two phases. Simple infection, that's why 20% will be admitted to the hospital, 5% ending in the ICU. So the 5% only to the ICU, 95 will be cured and they go home. So I look at this virus like any viral infection. The challenge is with the patient, the 5% who got admitted to the ICU. And I would like to tell you from my experience as pediatric infectious disease, and I have tremendous experience in Kawasaki disease, and I have seen several hundreds of Kawasaki disease in the United States and in UAE. There is a sub-entity of Kawasaki disease. It's called Kawasaki disease shock syndrome. The first case was identified in 2009. In the literature so far, around 35 cases. I have 4 cases so far. We took care of them at Al Jalila Children's Hospital in Dubai. Why I am saying that? Because when I looked at the 5% from COVID-19 patients who got admitted to the ICU, from the pathology, pathogenesis to clinical manifestations or to the laboratory findings, it is almost mirror image to Kawasaki disease shock syndrome. And I raised this awareness by sending a letter to the editor in order to look at it. And also if we can spread the word, because those patients are dying and people are desperate to find medication for them. In pediatric ID experience, the standard gold of treatment for those patients, Kawasaki disease shock syndrome, and this is the first time to be announced globally. Kawasaki disease shock syndrome equivalent to adult Kawasaki disease shock syndrome, those 5%. And the gold standard for them is high dose intravenous immunoglobulin, which we give 2 grams per kg over 12 hours, and we give aspirin initially for the first 1 week, high dose as anti-inflammatory, then very low dose as antiplatelet for 6 weeks or so, till we find that the echocardiogram is normal. So this is a personal experience, and not everyone familiar with this Kawasaki disease shock syndrome because it is a rare entity. It's worth for the scientists and my colleagues in the adult field to look into this treatment. And IVIG has been in the market or in the medicine for several years, and all of us, we are familiar with it and comfortable with it, and the side effects very minimal. This is about the COVID-19. Then the other part I would like to talk about it is why we have different countries, the most advanced healthcare system and the most developed country failed in this pandemic, and many countries failed. And if you look to, we have real cases that, or real examples, you have 2 developed countries, almost neighborhood, you can find strike differences in the death rate between country A and country B. And you know those 2 countries. Why? The question is why. The big question mark is why. It is simply because I will talk about agility. It has to do with the agility. Agility, the 6 perspectives of the agility are leadership. And my Dr. Al-Mheri, he just mentioned about the example about leadership, how in UAE leadership plays a major role in controlling this pandemic. Agile leadership, finance, operation, supply chain, as well as service delivery system and technology infrastructures. Those 6 agile perspectives, they should be working together hand in hand. They cannot be fragmented and independent. And the best example here is the failure of most of the countries to fight this pandemic, COVID-19. The best example, the developed countries who have been investing big money in technology and in military, and they underestimated the health sector. The end result is very clear: failure. So, and I would like to take this chance, you know, because UAE has been doing a great job here, and my nephew, who is an engineer, he's in UAE. He is the first one to come with the concept of global business agility definition, which means to connect all the 6 perspectives together in order to succeed. And I think this is big example in United Arab Emirates.
Professor, I think
okay, I can stop right there. Thank you.
Yeah, thank you. Very clear, and yes, connection. No man is an island.
Just I would like to say, Mario, if you don't mind, you know, just to be fair with my nephew, is an engineer, Muhammad Abu Hamur.
Perfect. It's absolutely something very interesting, and it's the connection and the interaction between. We are all intertwined in multiple ways. We have a comment and a question from Dr. Bassam Mohabud that I know is online, and I will ask him, however, to stay below 2-3 minutes, please. Our panel. I want to go back to our panel with a few questions that I know everyone here has. So, if that's possible.
Okay, well, thank you very much. I'm not going to add much to what everybody says, but I think it was a good chance for the world to see when physicians or doctors.
The sound is really not clear. Can you? It's very hard to hear what you're saying.
Okay, so just let me do this.
Much better. Yes.
Hello.
Yes. Thank you. Please.
So in a few seconds, actually, I'm not long time. I just want to say that it's good that this happened in a way, because the world saw or see how would the world look like when physicians and doctors lead. And I don't think they want us to lead the world again, because it's a lot of social distancing and it's a lot of washing hands and wearing masks. But I think as a physician who was interested in health innovation, I saw a fast forward to what we were talking about to be implemented in terms of technology. It is happening now, from telemedicine to delivering medication at home, to come to the hospital where this is needed. And I think very soon we are going to see a digital clinical trials. And I just have a question to the colleague, Dr. Dawoodi from Iran. When they sequenced the COVID, did it show that you guys have the S type or the wild type more than the other countries? Because it seems to be that there are some countries are hit by the wild type, like Iran, Italy, and maybe parts of Europe. And that's it. I'm not going to add anything more. Thank you very much.
Thank you. Fantastic. So we have the first question for Dr. Dawoodi. Doctor, are you there?
Yes.
The floor is yours.
No, based on the report of Pasteur Institute, the virus in Iran has no significant change in comparison to other viruses of the world. because it is an RNA virus, mutation is common in this type of virus, and the mutations that have been found are not very, they do not resulted in significant change in proteins that can ultimately change the pathogenesis of the virus. So by now, what we know is that the virus is similar to elsewhere. Thank you.
Thank you. I will go and I will take advantage of my position to be the first one to actually address again to the panel. I want to go to Ambassador Gooseby, if possible. You touched a few points that were very interesting, and particularly on the need of financing, on the need of funding, the international funding. And you also touched a very important topic on sub-Saharan Africa and what that could mean for the region here. That could be a reservoir of the virus, could be extremely problematic. Could you be going more in depth on the resilience of the funding system and the need for internationalization, so of an international effort directed to that? Of course, where we are moving is the exact contrary. Nationalism and isolation always been there, but now it's getting even bigger. We have seen that at the IMF level, we have seen at the World Bank level. So could you go a bit more in depth on that topic? Thank you.
Certainly, thank you. I think that as we saw with HIV, that unlike tuberculosis, HIV got an international attention. And I think it's complicated as to why HIV rose to engage political leadership on in a global discussion, but it did. There were many that were working for 20 years to get that to happen. I would say the first real breakthrough occurred when the ambassador from the UN, Holbrooke, in 2000, for the first time equated a disease with a security threat. And from my perspective, being kind of the public health person knocking on the door, within the Clinton administration, that was seen as the wedge that needed to be placed to bring the broader discussion forward that spoke about a shared responsibility with burdens of disease that were not in your own country, but offshore, and to connect the dots in looking at the medical, public health, and economic impacts of not seeing that global shared responsibility as something the donor community had an ethical charge to engage with. I think that the traditional approach of going through countries that had a history of colonization in sub-Saharan Africa, Southeast Asia, as the impetus to have the shared responsibility discussion was all that was on the plate before 2000. After 2000, the international community accepted, I think, for the first time, that they did indeed have a shared responsibility to support, mold, help in the response in those countries that were more likely to be the site of an outbreak because of the burden of disease that they historically carried. Seeing that acknowledging and identifying the outbreak in the initial country where it occurred was more of a humanitarian response, but also afforded a protective barrier in developed discussions, in developed legislatures, and with developed leadership. The discussion shifted to, and I'll just say this with this group, to meeting the outbreak where it occurred, so you are not responding to the outbreak in your own country further downstream. And that was when it pivoted. It didn't get traction until 2002, under the Bush administration, President Bush, Bush II, opened up the PEPFAR initiative, which before that date, the United States had not made anywhere near that level of an investment in a single disease that predominated offshore. And it became a platform that put the human resources, the pharmaceutical resources, the procurement distribution resources in a network that geo-mapped the HIV outbreak, that became the strongest medical platform on which to add diagnosis and treatment capabilities for NCDs. As opposed to the family planning or maternal and child health platforms, which are largely procurement distribution systems and not boots on the ground, as Naveed was referring. So I think that conversation, Mario, has got to be targeted and amplified. It's the conversation that was started but has not finished. I think we need to use all of the weaknesses that COVID has unearthed as examples of where we need to put strengthening exercises in place and rekindle the shared responsibility vision that was spoken to and is repeated in every UN General Assembly. But because of the political shifts in importance of donor resources, the role and responsibility donor resources play in both domestic responses and in global orchestration of responses, the COVID attack has given us an opportunity to reopen that discussion, concretize the relationships between multinational institutions, strengthen the IRH 2005 as the instrument that gives legitimacy, legislative justification, and perhaps creates the platform that extends us into moving resources in a different way to really put a global basement on healthcare and morbidity on the planet in a way that we have never attempted before.
Thank you, Ambassador. Quick follow-up question, and then I know that also Dr. Samir has a question about this. This follow-up question goes again to Ambassador Goosby, but also to, I think Dr. Madani will have something, Naveed, to say about this. Do you see this frankly happening? As an economist, I don't see that happening on the economic side for now. We actually need a miracle, I think, for that to happen. So to find the financing for this. Do you see this happening? And if it does, what is the fastest way, and this is the part that probably Dr. Madani will have to reply to this, how do we put those boots on the ground? How do we form quickly people that are able to actually be the sentinels of this diffusion, of the spread of the virus? Please, Ambassador Goosby, if you have.
I think that now more than at any time in my career, the opportunity for leadership to come forward and convene these discussions, it's palpable, okay? The desire for some entity to do that, be it a structural institution or an individual, I think the global community, I think the academic community needs to call foul and say enough already. We need to stop and look at this. We're smart enough to respond to this better, and stop taking the excuse, accepting the excuse of well, that country's response was blunted or unacceptable. Individuals suffered and died because of political decisions that were made or not made. It's not about a blame game. It's about embracing the fact that we have reached and evolved as a society and as a planet enough to say we do understand our shared responsibility to those who are not in our country, but out of our country, and that ethical mandate and imperative is strong enough for us to actually act. We talk about it, but we don't act. That's what my career in public health has largely been, with a few exceptions, and there's some big exceptions, but I'm hoping that this moment will be another exception, as occurred with HIV, that pivots this into people taking ownership, defining outcomes and objectives that can be linearly moved toward, and surveillance systems that allow us to know that we have or we haven't. We know how to do all of that, but we don't. So.
We can't hear you, Mario.
You are muted, Mario.
Yes, there you are. And Naveed, of course, if you can go on the topic.
That was beautifully said, Dr. Gooseby. Couple of things I want to allude to. One was the vaccine diplomacy that we had during the polio crisis. At the toughest time during the Cold War, scientists and academicians of U.S. and so the former Soviet Union were talking to figure out what they can do with the polio crisis. To paraphrase one of wonderful congressmen of the United States, but talking about it globally, we are better than this. We have to put aside our differences. I mean, imagine, just think about January, where we were as far as talk of war, another war coming up, early January. I mean, we started the new year with thinking that, oh my God, we're going to have another war in the region. And then the COVID crisis happened. What HIV did in 1980s and 1990s was pretty much took the science and policy and patient advocacy out of its box. Before HIV, we didn't have patient advocacy. Now we have libraries in hospitals teaching patients about their disease. HIV really did that. HIV, I mean, really, when you think about it as a scientist, polymerase chain reaction, PCR, just had won a Nobel Prize, I think in early 90s, in 1992, 93, I think. But now, because of HIV, all of a sudden, every laboratory is using PCR. Immunologists and biochemists and material engineers, they didn't collaborate. But because of HIV, I actually have a paper with a material engineer from MIT, for nanoparticles. So because of HIV, we did all these things in the past, 30 some years. And I think COVID is another opportunity that bringing other sectors, economists, sociologists, anthropologists, and then the politics has to go out the window, because this is a global crisis and it needs a global answer. I'm going to stop at that.
Fantastic. I know that Samir has a question.
Yes. May I? Thank you very much. I'm really, really grateful for this high level of discussion. And actually, I may reflect some of my concerns here, because the problem, as Dr. Ed had said, we need to have multiple therapy advanced at the same time with a multidisciplinary approach, etc. And this, in the current situation, is very much hindered by the structure of the pharmaceutical and clinical research structure, the model of the operation. And that's in itself quite a threat, I think, that would, in this situation, would need years to shift toward to what Naveed had already said about reaching a really comprehensive multidisciplinary cooperation. So my point is that how could we begin to think about bringing about some investment in those fields where you need multiple drugs, multidisciplinary approach, such a complex disease where you need many expertise from different sides of the globe. So this is one question. I have some other question, very much humbly, Dr. Gosby. First of all, he mentioned about the problems they did have in San Francisco, I think in California in general, about how to begin to deliver the services. Here, there is a certain similarity between the United States and between California, especially, and Dubai, actually, where we have already more than 2/3 of the services are being delivered by the private sector. So how did you manage to incorporate the private sector with all the financial and the structural differences? How did you, if you have managed, I don't know whether you managed, but at the end of the day, I would like to hear very much to hear about your experience regarding the cooperation and the model of cooperation between the private sector and the public health system. Another question would be also to Dr. Gosby is related to the WHO. You know, we are beginning to have, you know, some information that some, I don't want to enter in the politics of this. Some of those labs playing grade 4 labs playing with genomes and with viruses, with contagious viruses, were built all over, and they were built without any supervision of the WHO. And actually, what we are now witnessing is that there is a further weakening of the WHO, while it should become one of them, just like the nuclear program of the United Nations. It had been supervising every nuclear site. I think it's very important now to take in account that maybe we have to have a new approach vis-a-vis the functionality and the role of the WHO to be supported more, because if every lab will be proceed on playing with scissors and playing with DNA, etc., with those viruses, we know the outcome. A general question I would like to advance here is that we are very much concerned here how to stage the return to functionality. As I said, our aim is not here in the United Arab Emirates and in Dubai specifically, is not rapidly getting into normality, but do you have some ideas about what is the conceptual perception and how can we divide the staging of different periods where and on what scientific basis in return to functionality in a way or not? Thank you very much. I'm sorry for this wide spectrum of questions, but of course you've been so generous in exposing so many aspects of the issue.
Thank you, Dr. Samir. I'll add something. I think Dr. Benz actually on this topic, on this last question, he's probably the most fitting person to respond to this, meaning that you have a vast experience, not just as a science person, but also as a manager and a CEO of what it means to be on the front line. So you see what opening all the sudden which are now ready could produce. And you also spoke about what I would define an unsustainable financial model, which is very short cash in hand for companies that are in the healthcare system. How do you see those two things working together? So connecting to the question of Dr. Samir and this unsustainable financial model, how do you see that working out without a deep change? But a deep change will need time to do it.
Yeah, so if I knew how it was working out, I wouldn't be on this call, I'd be at the stock exchange. So these are some just guesses and speculations on my part. I think that what will come out of this in terms of the sustainability of the healthcare institutions will be some restructuring of the value assigned to different kinds of clinical services and the reimbursements that come with them. You know, on the one hand, there may be an acceleration of a move for so-called population medicine, where you're reimbursed on the basis of the populations that you take care of, rather than on individual bits of service. You know, a test, an X-ray, a surgery, so-called the traditional fee-for-service model. I think one possibly optimistic way to look at this is that the major drivers of the economy, other than healthcare, have realized for the first time, I think, in perhaps since World War I and the flu epidemic, just how devastating a public health emergency can be to seemingly unrelated parts of the economy. I think that there are going to be investment models in some of the things that we've been talking about, like how do you develop drugs without the traditional silos and intellectual property issues and so forth. In the cancer world, there's already, under the leadership of people like Andrew Lo at MIT, a move to develop these so-called mega funds or super funds, which large pension funds and so forth that are can invest in, where you get multiple shots on goals for drug development, and there's a creation of a pre-competitive space that tests these out. I think Naveed mentioned the fact that the clinical trial structure is being challenged to change already to allow for the testing of combinations, which has always been a problem when you have particularly drugs not yet approved by the FDA. You want to combine two untested drugs from two different companies, and getting the two of them to agree to share the data and share the outcomes, let alone share the materials, is almost impossible. But we've begun to see this in the cancer world around the precision medicine revolution. So there are models out there. And I think the open question is, will industries, manufacturing, financial services, many of the, the resort, travel, many of these areas that have been devastated by this, will they begin to see, and the markets, the stock markets, that there's a place to invest in the public health infrastructure, and that it actually can generate returns on investment, maybe not the maximum returns, but positive returns, so that it can be done. And these mega fund structures that Andrew Lo and some others have, where everybody throws in their intellectual property for a share of the collective rewards that come out of that. There may be, you may see the rise of some efforts to do that.
Thank you, Dr. Ambassador Gosby, for the answers to Dr. Samir in general.
Thanks, Mario. Those were great questions. I think the harmonization of the resources in San Francisco that went from public across private never really resolved the conflict. The private hospitals came to the table and could not shake the profit concerns that were paramount with their business model, and inserting the public good in it does not work for them. So it was one of the stranger conversations I've ever been in. It's not rocket science to figure out how we share the testing need or the surge capacity overflow. It gets pretty concrete quickly, but what doesn't get concrete is how you're going to impinge on Sutter Health's ability to maintain its profit during this outbreak. And I think it raises a much more fundamental discussion that's needed about the role of healthcare as a vehicle for profit generation. I believe me, I know we've lost this discussion, but I'm saying that unfortunately is the head that reappeared in the room. And it struck me that it needs to be a big problem for everybody to come to the table and say, I need to change the way I view my world to address this problem. We might be in that moment now, but I am quickly watching the chairs on the deck get back into the old business model thinking. The loss of an academic anchor in that discussion, i.e. that academic medical centers swept themselves into the competition, is part of what's missing. So there's not a foot on that stool. And I find myself at a loss, to be quite honest with you. I've been in the public sector my entire career, left academia to do PEPFAR. And when I came back, managed care had happened in a big way. I was out for 8 years. So at any rate, so I don't have an answer for you. I remain very frustrated. If it wasn't for the intervention of the mayor of San Francisco and of 6 other cities around the Bay and the governor, we would not have come to a conclusion. I think everybody would have done their own thing, is what I really think would have occurred in liberal San Francisco. So what can I tell you? So let me shut up there. I'm meandering around.
Thank you, Dr.
Just jump in very quickly. Contrast a little bit with Boston, where the academic centers have a huge share of the market, collectively over half of the marketplace in Massachusetts' academic health centers. They did throw in together, and they are taking huge financial hits for it. So it'll be interesting to see what comes out. I do think that, in an ideal world, with a federal government that's a little more functional than what we've got right now, that creating something akin to Social Security or these other federal trust funds that you feed into during calm times, so that there are emergency funds available during a public health crisis. It could be done. It could be done with tax on drug companies. It could be done with a surcharge on the health insurance companies. Could be done with a surcharge on the for-profit hospital systems. I don't think politically we could do that right now, but that would be an approach. Just like we have trust funds for Medicare, we have trust funds for Social Security. We do put a surcharge on high-income earners now for a Medicare trust fund. So something along those lines, I think, to provide the safety net, if you will, that takes away the profit argument, so that everybody throws in what resources they can for the next one.
That's very interesting. It opens all the door to another further discussion about the role of the state, probably, and the risking the economy, something that usually is done, and particularly in moments of extreme need, need like this, in multiple ways. This is the first time politics and policy in general takes a back seat in front of a virus, not even during the Spanish flu that happened. It's absolutely the first time this happened. Well, thank you so much. We don't have any more time, and I know that your agenda is full of other activities, so I will not take any more time. Let me wrap it up here. This was really, really fascinating. I must say that I really appreciate also the candor and the sincerity of everyone involved. That went more than just replying to a simple question, but bringing their real opinion. We will be having more, as we were already doing, and there will be new events such as this. The idea, as Dr. Samir said, is to keep feeding knowledge and committing to a more transparent world in which countries and different people from different countries share knowledge to be able to face this pandemic and others, why not, and other issues at a multi-level, in a faster way, in a better way, and also, why not, in a more equal way. Thank you again for your presence, and
thank you.
Incredible.
That is so great to have you. We'll keep in touch.
And I hope next time we can actually meet in person.
Yeah, in Dubai.
So I need something. Thank you again.
Thank you.
Thank you all. It's wonderful to meet you all, even if at this great distance.
Dr. Benz. Thank you, Dr. Gosby.
Thank you all. Thank you.
Thank you.
Thank you so much, really.
Thank you, دكتور بدر. أهلا وسهلا. شرفتنا. دكتور وليد كمان. أهلا وسهلا فيكم.
Thank you all. Thank you, Dr. Samir.
أهلا وسهلا.
حبيبي and man.
شكرا دكتور بدر.
الله يحفظكم. الله يحفظكم.
الله يحفظك. ويسلمك.
Thank you.